a devastating problem, and that affects the outcome of newborns significantly. To tackle this problem effectively, we have with us Dr. Venkatesh Karyamkonda sir. And to chair this session, we have with us two well-known neonatologists, Dr. Amol Girwalkar sir and Dr. Vijay Mari sir. However, due to some inevitable reasons, Dr. Venkatesh Karyamkonda sir could not attend the program in person, but he is going to guide us online.
Hello, sir. Slides are very much visible and you are audible. Thank you. Yes, sir. Thank you very much, sir. I would like to introduce Dr. Venkatesh. Sir is a senior neonatal consultant and a senior lecturer at Leicester University Hospital NHS Trust. He's an eminent speaker and a researcher with a lot of national and international publications. I would like to invite sir to talk about neonatal sepsis, nip in the bud. Over to you, sir.
So for those who don't know where Leicester is in the middle of England, where the red arrow is, and it has iconic places to visit if you ever come to Leicester in UK. There is a Richard III, the king, the medieval king of UK museum, and it has a very famous National Space Center with lots of replicas and very educational museum for children. And an iconic clock tower about 200 years old in the city center. And Leicester is blessed with extremely vibrant Asian community with a very famous road called Belgrave Road, with the highest turnover named in the British history and also in Guinness Book of World Record, called Golden Mile. So this is a place worth visiting if you ever are in Leicester. I have nothing to disclose. And the themes today is essentially to give you an overview of neonatal sepsis. But essentially my aim, and I hope I achieve this aim, is to give you a toolkit of evidence-based updates that are available in the world literature, especially from resource-limited settings, for you to take home some of the evidence-based interventions and implement them in your local areas to prevent infections and treat them as per the new evidence that there is. So before we embark on many of the slides, I'll run very quickly. But before I do that, the talk is brief, but I have many slides. So I will rush past them very quickly. But if everyone wants a sight of my slide, I'm happy to provide these to the committee and they can share it with you. So the terminology which is important is to identify the different terminology in terms of neonatal infection is cleaning versus sanitization, disinfection, asepsis, and sterilization. So cleaning is essentially removal of dirt and visible macro dirt that you see. Sanitization is reduction of microorganisms to safe levels. Disinfection is to remove most microorganisms, but not the highly resistant ones. Asepsis is removal of disease-causing microorganisms. And sterilization, as you will be aware, is killing of all living forms to make it aseptic and sterilized for infection prevention, especially for invasive procedures. So as we all know, neonatal sepsis is a clinical syndrome in infants less than 28 days of age with systemic signs of infection, along with isolation of a bacterial pathogen from the blood. And it's divided essentially into early onset sepsis when the presentation is in the first 3 days of life, and late onset sepsis when the presentation is after 3 days of life. Now, this definition might differ in various countries, even quoting 7 days or 48 hours, but many publications divide it as early onset less than 3 days and late onset is after 3 days. It's important for categorizing this based on the etiopathogenesis. Although we have many pathogens causing neonatal infections, we'll concentrate on bacteria because that's the most important one. And due to limitation of the time, we will not discuss viruses and fungi. Why bother? Why should we do this? Essentially because in India, 250,000 deaths will be directly associated with severe infections due to pneumonia, meningitis, septicemia, and unfortunately, healthcare associated, which is also called nosocomial infections, are 9 times higher in the developing countries compared to developed world. And obviously, the mortality rate of neonatal infections in low birth weight is quite high, up to 26%. And babies who survive neonatal infection have prolonged hospital stay, and they have later neurodevelopmental disability like cerebral palsy, vision and hearing disability. And the key global target by 2030 is to reduce the neonatal mortality rate to below 12 per thousand live births. And we can possibly achieve this only by introducing neonatal infection measures, prevention mostly, because the treatment is too late, and many multi-drug resistant organisms are now amenable to many antimicrobials. So I think our concentration should be mostly prevention, nipping it in the bud. So the main pathogenesis of early onset sepsis is primarily the ascending infection in the mother or colonization in the mother due to bacteria, and rarely descending from the mother's body to the genital tract and the birthing canal. And late onset sepsis is primarily transmission of pathogens in the surrounding environment during care delivery to the mother and the baby. And rarely it is a late manifestation of vertical transmission of the common organisms that we see in early onset sepsis. And then we need to have a vulnerable infant. And in here, we know that preterm babies are at risk because of low birth weight, premature body, and the breakage of the protective barriers, especially the skin and the mucosal barriers, due to transmission of hospital-acquired infections and cross-contamination due to the care that we have to provide in the maternity, in the transitional care, postnatal wards, and the neonatal intensive cares. Although these common pathogens in the early onset sepsis and late onset sepsis are highly dependent on geographical distributions, it's well established that early onset sepsis, the primary bacterial pathogens are group B streptococcus infections and E. coli, whereas late onset sepsis predominating organism is coagulase negative Staphylococcus aureus, and E. coli. Sadly, in the resource limited settings, there is a high emergence of multi-drug resistant organisms, namely Klebsiella pneumoniae and Acinetobacter, which are causing havoc in many health settings in resource limited areas. So let's look at a case study that is hypothetical, but might give you some idea as to what we might do in the next coming slides. So we have a 30-week gestation mother who is admitted with pre-labor prolonged rupture of membranes for more than 24 hours. She's in labor pains with no antenatal care and from low socioeconomic status. So these slides will demonstrate to you the evidence that we need to use that is available to provide the best care to the mother and in the baby. So what are some of the prepartum, intrapartum interventions that are evidence-based? There is very good data out in the developed world that high-risk strategy for identification of group B streptococcus colonization and giving intrapartum prophylaxis with antibiotics reduces early onset sepsis. And obviously, there are a lot of data to suggest limited vaginal examinations during labor, and a very effective hand hygiene is essentially a common theme that you'll see throughout this lecture. What is the evidence in prevention of colonization with bacterial pathogens in the mother? There are some very good papers on the use of 1% chlorhexidine gluconate vaginal cleaning has shown 50% reduction in the pathogens. There is a big trial in Malawi to be soon published in the next year or so, which is comparing chlorhexidine and octinidyne vaginal swabs in the mother to prevent bacterial colonization and prevention of early onset and late onset sepsis. And it's very clear now that there are a lot of publications suggesting that we should deliver babies as far as possible vaginally, because cesarean section leads to abnormal microbiome, especially pathogenic microbiome that increases the risk of neonatal sepsis and mortality in the postnatal period. What are the intrapartum measures? And I already suggested to you, there is fantastic data to suggest that intrapartum prophylaxis against group B streptococcus infections is a mainstay. First of all, identification through rectovaginal swabs to identify bacteria within the mother's birth canal, and also GBS colonization. In UK, the death rate is extremely high on GBS colonized babies. 10% of babies get infected in the early onset sepsis with GBS, and the mortality remains high. So we actually do a high risk strategy of identifying and giving them intrapartum prophylaxis, and those are the indications that are well known. And what are the things that we can do immediately after birth? So there's a recent publication just a few months ago in Nature, which is very interesting. What this group has done is they collected umbilical cord blood cultures and compared it to postnatal blood cultures and demonstrated very good bacterial sensitivity in picking up bacterial infections in the umbilical cord, and good correlation with positive umbilical blood cord cultures with early onset sepsis. And also, when the blood cultures, the umbilical cord cultures were negative, those babies did not have early onset sepsis. And it was definitely more reliable in terms of picking up compared to postnatal baby blood cultures. So what they're recommending is that umbilical cord blood cultures should be considered as a routine for early onset sepsis. Of course, there are cost implications in resource limited settings, but it's a very good one for developed countries. And I think more studies will be done to see if this is reproducible in other major studies. What about prevention of colonization with pathogens in resource-limited settings? And I came across very robust data about the use of birth kits. I'm sure Dr. Amte's team is already using this to decrease late onset sepsis and mortality. Birth kits containing soap, razor blade, cord ties, alcohol swabs, plastic sheets, and a gauze reduces puerperal sepsis, neonatal tetanus, perinatal, neonatal, and infant mortality. So very good data, and published in International Health in 2020, if anybody wants to review that data. What about promoting colonization of healthy microbiome in the baby? Hopefully, that will prevent pathogenic organisms taking over. And there is a lot of emerging data in the developing and the developed world. And one of those is kangaroo mother care. Just a very simple kangaroo mother care decreases infections in less than 2 kilogram babies up to 40%. And you can add 25% more if it is started immediately after birth. Fantastic data, and those are the papers right in 2010 to 2016 and 2012. So there's good, robust data, and you guys are very, very experienced in the early use of colostrum and early mother's own breast milk. We are using donor milk because the breastfeeding and breast expression rates are extreme developing world. So now we have donor milk banks where we get donor milk to start early introduction as buccal colostrum or oropharyngeal instillation of tiny amounts of breast milk. And they have shown to decrease neonatal sepsis and necrotizing enterocolitis and improve mortality. And then I'll provide you some data about probiotics and lactoferrins. So it's a large study done by Deshpande in 2017 of a systematic review of 23 RCTs of probiotic use, mainly Bifidobacterium and Lactobacillus, which showed reduction in NEC, late onset sepsis, and all-cause mortality. A large study set up in 2017 of major hospitals, in one of which I worked as a student, is yet to be published, comparing multi-strain probiotic supplementation with placebo to prevent neonatal sepsis in less than 2-month-old. I'm keenly awaiting this study. I think it will inform Western countries as well. And there is robust data from Cochrane review by Pami et al. In 2020 showing that oral supplementation of lactoferrin decreases late onset sepsis, but it may not help with NEC, all-cause mortality, or future neurodevelopmental delay. However, low quality may be. The studies were of low quality to come to this conclusion. If lactoferrin is combined with probiotic, it not only decreases late onset sepsis, but it also decreases NEC stage 2, which seems to be an area that we need to focus on and do few more large randomized controlled trials to establish this as a routine practice to prevent, especially in developing world, where prevention of late onset sepsis and early onset sepsis is extremely important. What about interventions to maintain skin integrity in these fragile neonates? And there is very good data on a bundled approach in terms of preventing pressure sores, careful diapering, using barrier creams, providing skin-to-skin care and kangaroo mother care, optimizing the humidity, temperature, and nutrition decreases neonatal infection rates. And there is a very good publication in 2004 about the use of sunflower oil as an emollient, which reduces infections in the neonates in the hospital and community settings. I think there is enough data to suggest that skin emollients do some work, but we need a bit of safety data for the Western countries. I think lots of you guys are already using it in the developing world, but more studies need to come through with regards to emollients and antiseptics combined, that they are more helpful in reduction of nosocomial sepsis. And what about the decolonization interventions? There's a fantastic publication of a very large scale study showing 4% chlorhexidine just applied to the umbilical cord in high mortality settings decreases nosocomial and future neonatal infections and mortality as well. So this could be easily adopted because chlorhexidine is an extremely cheap antiseptic. And similarly, in the neonatal period, in the intensive care and in the community-based settings, 2% chlorhexidine bathing and skin cleansing, especially if is combined with an infection prevention intervention bundles, has shown to reduce neonatal infections and mortality. And there is emerging data to show that topical application or nasal application of mupirocin for methicillin-resistant Staphylococcus aureus and similar organisms is quite effective. There is a bit of conflicting data in the literature about its usefulness in all settings, but I think this should be worth considering in areas where there are high healthcare-associated infections. And there is good data from Cochrane reviews of systematic reviews suggesting that the use of chlorhexidine skin preparation before IV cannulations and central venous cannulations decreases antimicrobial tip colonization. And there is a large UK study which is currently undergoing recruitment, comparing 2% chlorhexidine with 2% chlorhexidine along with 70% isopropyl alcohol in reduction of CVC colonization and CLABSI rates. Again, a good study to await results on. So what are some of the core principles of infection prevention in the NICU? I don't have much time to go through these, but these are the bullet points. It needs to go right back to designing of the maternity and the neonatal intensive cares. When we are designing them, we should have an infection control angle to prevent and improve our infections and infection transmissions through good innovative designs of the maternity and the neonatal intensive cares. And also investing in medical grade equipment which are easy to disinfect and sterilize, and also continuing the innovative studies to develop newer endotracheal tubes, umbilical catheters, urinary catheters, chest drains, and central lines. But always concentrating on evidence-based local infection prevention bundles have got very good data to suggest always help in prevention of neonatal infections and nosocomial infections. And I can't emphasize the importance of hand hygiene, which you all are aware. And I'll introduce you to something called aseptic non-touch technique. If adopted along with hand hygiene, significantly reduces healthcare-associated infections in invasive procedures. And the importance of neonatal surveillance locally, regionally, and nationally to prevent outbreaks, along with antibiotic stewardship to prevent multi-drug resistant organisms. So some simple illustrations to demonstrate when we're designing maternity and neonatal units, we should understand the adjacency of these structures and also the free flow and how the work flows and patient and staff flows help in prevention of infection. And within the maternity and the neonatal system, how the adjacencies of high dependency, intensive care, special cares, postnatal wards, transitional cares allow for smooth transition and also barrier nursing if infections are identified to prevent outbreaks. And some useful information if anybody wants to read up this further, detailed pictures, architectural designs are available in these documents freely through the Google BAPM website. And within the hospital environment, there's emerging data to show that in resource limited settings, having removable, movable barriers because of a lack of space and lack of resources, if a multi-drug resistant organism is identified, is very difficult to isolate a baby and a mother or baby from other babies in resource limited settings. So movable barriers seem to be an important concept in enabling isolation and prevention of transmission of MDROs. And there is good data emerging about waterless hand hygiene using chlorhexidine and alcohol-based sanitizer, which we have seen during COVID-19 outbreak. And also water-free patient care, including removal of sinks because waterborne areas have infections, quite toxic infections actually, and easily transmitted in the patient areas. So removal of them and using hand gels and chlorhexidine seems to be a good balance in resource limited settings. And there is a good paper on a very cheap, low cost vinegar decontamination of sink drains and multiple use medical equipment shown in 2019. And I think this could be easily adopted in low resource settings. And multimodal cleaning interventions, along with all the other ones that we described, actually show dramatic reduction in nosocomial infections. And in some units, they have used fluorescent markers or gel dots to assess cleaning quality and provide regular feedback to staff and parents, really, to see how their hands are and whether hand hygiene is given a priority. And then that regular PDSA cycles can be done based on that to see adherence to the standards. And some examples of medical grade equipment that enables easy cleaning: washable keyboards and mouse, which are harbingers of severe infections and colonizations and transmission to staff and consequently to patients. And so what are some of the key infection control measures? Now, I can't highlight everything, but I'll concentrate on aseptic non-touch technique and about the importance of hand hygiene and visitor management and education of staff and parents, especially about your infection control policies and having a dedicated infection control manual. And these are some of the key antibiotic stewardship that I have introduced in my hospital with very effective control, not only of nosocomial infections, but also dramatic reduction over the years since implementing these strategies. I'm very happy to discuss this with anybody who is interested due to lack of time. And I was also instrumental in developing evidence-based guidelines for early onset sepsis and late onset sepsis, along with surgical prophylaxis, we being a very big tertiary referral center for neonatal surgeries, cardiac surgeries, and neonatal and pediatric and adult ECMOs, with infection control packs available both digitally and manually and kept up to date by dedicated team for people to use as and when they need. And these are some of the examples that I developed of guidelines that are in laminated sheets and close to the staff and the patients, so that people can follow early onset sepsis and late onset sepsis. This is one of the flow sheets for early onset sepsis management. This is late onset sepsis management. And these guidelines are based on current advances in antimicrobial therapy and also guidance from national publications based on multidisciplinary team meetings and regularly updated every few years and updated in our guidances as well. And I would like you to introduce you to KP calculator for those who don't know. They are freely available Kaiser Permanente neonatal early onset sepsis calculators to identify high-risk neonates. They are easily available on the Google to be adopted in each individual units. And based on the risk factors in the mother and the baby, it gives you the risk factor of infection, risk of infection in the baby, and advocates what kind of treatment you need to institute. But just be aware, it is only to be applicable to infants about 34 weeks of gestation. And in UK, the government and the National Health Service proposes that having a prospective audit in place makes it safer to use this tool, which is comparable to the risk factors and clinical indicators which we use for identifying high-risk infants. So some of the key neonatal guideline points are: assessment of risk factors and clinical indicators help in starting antibiotics. So if you have one red flag indicator or two or more non-red flag risk factors or clinical indicators, then the baby deserves to have antibiotics within 1 hour of decision to treat. And that is subjected to weekly audit to make sure that we come close to 90 to 100%. Which is difficult, but it should be adhered to because that shows improvement in mortality based on neonatal infections. You should always consider the emergence of viral infections, especially in a baby whom you're thinking of sepsis and has neonatal encephalopathy or meningitis. Think about herpes simplex virus and starting of acyclovir early, and stopping antibiotics as soon as we know that clinically and biochemically the baby does not have infection. How about preventing cross-contamination in the hospital setting? So we know that the biggest issue about nosocomial infection is the transmission or cross-contamination of infection from the hospital environment to patient environment. And that is increasingly contributed due to the complex care that all of us have to provide to our babies due to multiple people working in those areas, and also shift system coming up with different teams trying to save these babies, but actually with improper hand hygiene and infection control policies, there is easily cross-contamination, which then enters into the high-risk neonates and causes havoc and mortality. So can't emphasize the importance of hand hygiene. It's a single most step in the infection prevention strategy. Very good WHO guidance on how to implement this. And I'm chuffed to see in many Indian low-resourced hospitals, including a visit to multiple hospitals in Pune, shows that many of us are already using this. I think the important thing is to make sure that everybody is following this by doing regular audits and actually publishing them online and also in the staff areas to improve compliance, which I do on a regular basis. And adhering to the WHO 5 moments of hand hygiene, especially the last two, after touching a patient and after leaving the patient zone. Do we decontaminate? And we have a big challenge in developing world. In our unit, we only do 60 to 75% of the time. So my audits usually concentrate on the last two steps, is what we are doing when we touch the patient and when we are going to the next patient. And when we're just about leaving the patient zone to go to a computer, do we decontaminate? The 5 moment of hand hygiene suggests that we should decontaminate. If it is not soiled, then we should use alcohol gel. If it is soil, we should be washing our hands right till the elbow and then moving away from that area. Yes, it is resource intensive, but this is one of the surest way of preventing nosocomial infections. And then at every moment of contact with the patient, we need to risk assess. Do I need gown? Do I need to wear gloves? Do I need to wear protection to my eyes and my mucous membranes by the masks and the eye covers? And ANTT. Now, if you forget everything about my lecture, I hope I can share some of the importance of aseptic non-touch technique. It was primarily introduced by a very good nurse in 2011 called Rowley, and he published his data, which is adopted in almost all hospitals in the UK with very good effect on reducing nosocomial infection. And what it essentially is about maintaining an aseptic field during invasive procedures by not touching the key parts and key sites, thereby reducing cross-contamination and prevention of infection. It has 6 core steps. One is hand hygiene, then wearing the correct glove, then protection of the key part and the key site, wearing sterile gloves and not touching those sites, then disinfection of the key part, and then maintaining the aseptic field management during and after the invasive procedure is done. And this is very nicely demonstrated in this PDF document about the various steps involved in prevention of infection giving to the babies when we are accessing the IV cannula or a central venous catheter. It goes through steps of 1 to 12, and this was implemented, taken from Rowley's experience in Bangalore neonatal intensive care. Very recently, Shettigar published that data and demonstrated a reduction, a dramatic reduction in nosocomial infections as close as in 2021. And this is the basics
Sorry to
of...
interrupt you, sir. Last 2 minutes, sir.
Yes, so I'll just show this slide and then we can stop. I think the slide is about 4 minutes and then we can stop. Thank you. I'll stop over there due to limitation of time. Hope this was helpful. Thank you.
Th- Thank, thank you very much, Dr. Venkatesh. It was a wonderful lecture, and it's a vast topic we all know, but you have covered very nicely all aspects of aseptic precaution and a lot of take-home messages to all of us. Thank you very much. Thank you. Thank you for joining us. Thank you.
Thank you so much, sir. Now I request the chairpersons to proceed to the felicitation area. For the next talk we have is on surgical emergencies.
Okay, good afternoon, everyone. I think since we're running very short of, behind schedule, and since all of you know the two topics very well, I'll request Dr. Vishal to directly begin his talk. Thank you.
Good afternoon, everyone. My talk is in two parts. One is on the management of acute scrotum, and the second one is surgical management of empyema. Now, what is acute scrotum? It is a sudden onset of scrotal pain with or without swelling and erythema. Though there are many non-emergent causes, testicular torsion is one of the most important differential diagnosis and needs to be detected early to avoid testicular loss. Though age at presentation, physical findings and ultrasound with Doppler helps in the differential diagnosis, sometimes they can be inconclusive or erroneous, and sometimes we need to go for early surgical intervention. These are the different causes of acute scrotum. So I will go into details of all of them, but mainly on torsion testes. There are two types of torsion testes. Torsion testes occurs as a result of twisting of the cord, thereby compromising the testicular blood supply and perfusion. Basically, there are two types, extravaginal and intravaginal. Extravaginal, the torsion happens outside the tunica vaginalis, whereas intravaginal, it is within the tunica vaginalis. And extravaginal is more common in younger children because the tunica vaginalis is not adequately fixed to the Dartos layer. And intravaginal types are more seen in adolescents. And the commonest predisposing factor is a Clapper-Bell type of deformity, because here the tunica vaginalis invests higher up in the cord, thereby predisposing to the torsion. So mostly they occur before 3 years or after puberty, very rarely seen after 25 years of age. The presentation is usually a sudden onset of acute severe pain in unilateral testis, thigh or lower abdomen, often associated with nausea, vomiting. Sometimes before the actual event, the patient may have a couple of episodes of intermittent pain. The scrotal edema and inflammation will develop over a period of time. There are certain important signs to identify testicular torsion. One is because of the torsion, the testis goes up, that is known as the Brenzel sign. And because of the same reason, the scrotum is pulled up, that is called as the Jair sign. And most important test which we use is Prenz sign, because in torsion, if you lift the testis, the patient will not get relief. Whereas in epidermoarthritis, which is the other differential diagnosis, there will be some relief. And absent cremasteric reflex is also used as one of the important signs in differentiating testicular torsion from epidermoarthritis. There is an objective score which is used to find out the risk of testicular torsion, known as the twist score. This is based on following criteria. One is the testicular swelling. If the testis is very hard, they are assigned score of 2. And absent cremasteric reflex, nausea, vomiting, and hyaluronic testis is assigned 1 score. And if the score is less than 2, it is very unlikely that it is a testicular torsion. But if it is 6 to 7, it is very high likely that we are dealing with torsion and no time should be wasted in trying to do investigations. 3 and 5 are doubtful cases. One may do an ultrasound to find out if it is easily available and you have a very good radiologist backup. These are various investigations done, but one of the most commonly performed investigation is a ultrasound. Ultrasound will show the twisting of the cord as well as perfusion to the testes, and should be done only when the diagnosis is doubtful. Some of the recent advances in diagnosis may also be used, but they are not easily available. What is the management? Is a prompt surgical exploration. If it is done within 6 hours, we are able to save the testes. Delay in the diagnosis and the treatment will result in testicular loss, as seen in this picture. The steps which we do is, one, first we explore the scrotum. There are different incisions which can be taken. Explore and diagnose the torsion. This is the intravaginal torsion. We untwist the torsion and apply hot mops. The anesthetist gives 100% oxygen. In the meantime, we explore the other side, because we need to, the pathology is common, though there is no torsion, but the predisposing condition is also there. And then wait and see for the change. Here there is slight change in the color. Then when there is, when we are not sure, then we sometimes prick it with the needle to see if there is good flow, good blood flow. If there is good blood flow, we try and save the testes. Sometimes we even do capsulotomy to preserve the testes. Always, once this is done, if the testis is viable, it is fixed. If the testis is not viable, it has to be removed. And the contralateral side also needs to be fixed, because there is a risk of, significant risk of contralateral torsion in future. Testes can also undergo torsion if they are undescended. So always the child who has undescended testes should be also informed during the waiting period. Normally we operate them by 6 months to 1 year. So in the waiting period, that they may develop torsion, they may develop hernia. So they need to be informed so that if they develop, they can be treated immediately. Perinatal testicular torsion can also happen. So sometimes you see a newborn baby who has a hard testicular mass. It could be a torsion. So one of the differential diagnoses is a torsion, though there may be hematocele, or sometimes even meconium can go through the patent processes into the testes, into the scrotum. So they need to be explored. Previously they were treated conservatively because there is a chance that some of these testes may be saved. Now this is another differential diagnosis. These are the various remnants of the Wolffian and the mesonephric duct, and they can also undergo torsion, most commonly seen in prepubertal boys. When the hormone level starts rising, they go increase in size. And if there is delay even on ultrasound, this can result in epidermal swelling and may be misdiagnosed as epidermoorchitis. This is one of the signs, blue dot signs. Sometimes you may be able to see on physical examination there will be differential tenderness. Part of the testis may be tender, some part, and the other part may be normal. This is how it looks intraoperative. Epidermoorchitis is another common cause which we need to consider. And here the important thing is that onset is insidious, the cremestral reflex is preserved, testicular lie is normal, and on ultrasound the epidermis is enlarged with increased vascularity. And the treatment is usually conservative. Idiopathic scrotal edema is another condition which we often see. Usually many times we don't know the cause, but many times we think it may be because of an insect bite or some allergy or angioneurotematic edema. If you examine these testes, the testes are normal in size, there is no tenderness. Only there may be skin tenderness. The treatment is analgesics and antihistaminics. Testicular trauma can also be one of the differential diagnoses of acute scrotum. And usually there may be a physical abuse. So it depends, the severity depends on the severity of the trauma, and sometimes they may need exploration because of a massive hematoma which can cause damage to the testes. Sometimes this following trauma also torsion can happen. So this needs to be considered if the patient doesn't settle after management of conservative management of trauma. Obstructed inguinal hernia is also present as acute scrotum. They also need to be treated urgently. If possible, the taxis reduction should be done, and then immediately within 24-48 hours, the child should be posted for surgery. Sometimes peritonitis can also present as a scrotal swelling and redness. This is because there is a patent processes through which the pus enters the scrotum and can be misdiagnosed as an acute scrotum. So always you have to have a detailed clinical examination as well as the history to know that it could be a secondary problem, not a primary pathology. Tumors can also sometimes present as acute scrotum. They need to be investigated and treated, usually by a high inguinal incision. The take-home message is that it is a frequently encountered emergency, and our responsibility is not to miss torsion because it can have medico-legal implications. The child may lose the testes. Twist score helps in decision making, and ultrasound may be erroneous at times, and no time should be wasted if torsion is most likely diagnosis. A negative exploration is acceptable over a testicular loss. So shall I continue with the next? Shall I continue with the next? The next topic is surgical management of empyema in children. So empyema thoracis is accumulation of pus within the pleural cavity, as you all know. Now there is a brief history. This is the contribution of many of our forefathers who have contributed to the management of empyema. It was well known even 2000 years ago by Hippocrates, who described natural history of empyema and realized that the drainage will cure. Then these are various doctors who have, and the famous physicians Dupuytren's and Sir William Osler have died of empyema. The recent development of introduction of antibiotics in 1940, as well as intrapleural fibrinolytic therapy and recent surgical advances in minimal invasive surgery, video-assisted thoracoscopic surgery has decreased the use of traditional thoracotomy in the management of empyema. There are various causes of empyema, but in today's talk, I'm going to restrict only to pneumonia, parapneumonic infections, and tuberculosis I'm going to avoid, and all the other causes are mainly surgical. Now, the organism responsible for empyema depends whether it is a community-acquired infection or hospital-acquired infection, as well as on the immunocompromise, as well as the immunological status of the child. Gram-positive organisms are mainly responsible for community-acquired, whereas gram-negatives are seen in hospital-acquired infections. These are various symptoms, but you should suspect empyema if a child admitted with pneumonia fails to respond even after 48 hours of appropriate antibiotic therapy. So one should be on the lookout for development of empyema. These are various signs which you all know. Shift of trachea, though empyema is a space-occupying lesion, shift of trachea is usually not seen because of the underlying lung collapse. These are various complications which can happen in improperly treated or untreated empyema. Now, as far as the management of empyema is concerned, we have to know the stages of empyema because the management depends on the stage at which we see these children. The first stage is a exudative phase, which is mainly a reactionary fluid to the infection. The second is fibrinopurulent stage, where there is deposition of fibrin, and organization phase, where the fibrosis occurs. These are the thoracoscopic pictures representing all the three phases, and it is a continuous process, and progression will continue if not halted or inappropriately managed. These are the stages, pictorial depiction. So exudative phase in the first 3 days of life, the fluid is thin and the pH is usually more than 7.3 with the glucose of more than 60 and LDH of less than 1000. And the gram stain and cultures may be negative during this stage. This is an important stage because if this stage is not treated adequately, it can go into a difficult stage. Then the treatment becomes more difficult and results are not so good. The pleural fluid accumulates more polynucleosides polymorphic lymphocytes, and there is a deposition of fibrin, and it becomes more purulent and viscous. So antibiotics will not penetrate here, so we need to do a proper drainage to cure this problem. In organization phase, it is a nature's mechanism to limit the infection. So there is more involvement of fibroblast, deposition of fibrin, collagen, and this causes on both the pleural surfaces, causing encasement of the lung, and the septic foci within contribute to chronic ill health, failure to thrive, and poor respiratory reserve. As the process continues, the fibrosis become more severe, causing more collapse of the lung and restriction of the chest movement, and eventually can cause also scoliosis because of crowding of ribs. These are investigations done, most important investigation being the pleural tap. And based on the pleural tap, we decide, based on the pH, WBC count, LDH, proteins, sugar, we decide whether ICD is necessary. pH is less than 7.2, LDH more than 1000, or WBC count more than 3000 is an indication to put an ICD. If it is below that, we can still treat conservatively just with antibiotic and supportive measures. There are various radiological investigations which are done. The most simple and the basic is a chest X-ray, but chest X-ray usually may miss a low volume empyema, and we may have to take a special X-ray in lateral decubitus position or lateral X-rays to find out the obliteration of costophil. But ultrasound has become the main investigation of choice in diagnosing empyema. We can identify the nature of fluid, whether it is loculated or free-flowing, whether there are septations, amount of fluid which is accumulated, and radiologists can guide us to the optimal site of thoracocentesis and insertion of ICD. Serial ultrasound is helpful to monitor the progress of the disease. CECT also is an important investigation, but it shouldn't be advised in every case of empyema. We have to be very selective when to get a CT scan done. It is mainly used to find out the anatomical details, the extent of the disease, the necrosis or nematoceles, lung abscesses, underlying lung anomalies, mediastinal involvement, and the differential diagnosis of rare malignancies. It also helps surgeon plan surgical treatment. So the disadvantage of CT scan is it doesn't identify the septation and loculations, and because there is no blood supply in the septae, so it is not picked up on a contrast, and there is a risk of increased radiation exposure. So one should not do that left, right, center. One should use caution when advising CT scan. It is most useful when there is failure to aspirate pleural fluid and failing medical management. Whenever you advise CT scan, always do a contrast enhanced CT scan. Many times it is commonly observed that when you go for a X-ray reporting, the radiologist is not able to clearly differentiate between empyema and pneumonia. He will do a plain CT for his sake. Never get it done that way. If you are doing a CT, always do a contrast enhanced CT. Bronchoscopy has a limited role in the management of empyema. It is only when foreign body is suspected. Bronchoalveolar lavage is not necessary because we have pleural fluid for bacteriological analysis. Tumor should be considered as one of the differential diagnoses when you are dealing with non-resolving empyema, large fluid collection, and when the aspirate is hemorrhagic and showing lymphocytes. And CECT is diagnostic in such cases. There are various complications which can occur in empyema if they are not managed properly, and they require ICU care and aggressive management. I won't go into the details of each. Now coming to the management of empyema. This empyema management is based on the different stages. In the first exudative stage, it is mainly the antibiotics and supportive care. Pleural tapping is done to know whether ICD is necessary. And if, as I mentioned, the criteria on pleural examination, ICD may be put if on 2 occasions, if the pleural tap shows that the pH is less than 7.2 or there is failure of completely evacuating the fluid, then, or it recollects, then you may have to put an ICD. The most controversial management comes in the second stage. The antibiotics and ICD is always put, Now there is a controversy whether one should use fibrinolytics and or video-assisted thoracoscopy. This is a very crucial stage. If you manage this stage properly, the child will not land up in stage 3. Stage 3 is when the already fibrosis has occurred, the lung is encased, and there is no option then to do surgery. And usually thoracotomy is better than VETS when the child has already reached stage 3. Medical management, I won't go into details because you all know this is antibiotics and supportive measures. Oxygen. Chest physiotherapy has no role. Only you have to give chest expansion exercises, incentive spirometry, and those things work. The chest physiotherapy doesn't work. Intercostal tube, I already mentioned the indications. Now here there is a controversy whether one should use a pigtail catheter or you should put a large bore catheter. We as surgeons usually prefer to put a large bore catheter because empyema, as you know, is pus, and the pus can cause these tubes to get blocked. The small bore tubes are used mainly by the interventional radiologist and pulmonologist, but these are used preferably when you use fibrinolytic therapy. When you use these are useful, but usually they get easily blocked. The position is 5th or 6th intercostal space in mid-axillary line or just in front of the mid-axillary line. There are various techniques to use, but by and large, do not use a trocar type of, because they are very dangerous. You can go into the lung or left side, even enter the heart. So open technique is safer, or radiologically guided pigtail catheters can be used as mentioned. When do we remove them? When the fluid output is less than 1 to 2 ml per kg per day on 3 consecutive days, or less than 20 ml per day, then we remove. Plus there has to be clinical and radiological improvement. Fibrinolytics, these are often used in the second stage of empyema when there is loculation and septation. Results are better if you use it within 7 to 10 days. Various fibrinolytics are used and they can induce fever, bleeding, anaphylaxis, discomfort, and blood staining, more common with streptokinase. Bronchopleural fistula and bleeding diathesis are absolute contraindication for using fibrinolytics. Pleural thickening, intraparenchymal abscess, and necrotizing pneumonias can suggest that the treatment of fibrinolytics will not work. These are various drugs which are used. The most commonly used are the urokinase, streptokinase, and tissue plasminogen activator. Urokinase is the most preferred because it is relatively safe compared to streptokinase. Streptokinase is relatively cheaper, but it can cause anaphylactic reaction, hemorrhage. TPA is an expensive drug, and newer trials in combination of streptodornaz is used to make the empyema fluid more thinner for easier drainage. These are the dosages in which they are used. Now coming to the surgical intervention. So when do we intervene surgically? When it is not effectively controlled with antibiotics and intercostal tube drainage, presence of significant respiratory compromise, thickened pleura, crowding of ribs, scoliosis. If ICD drainage output decreases but the clinical deterioration continues with persistent effusion, also is an indication for surgical intervention. There are two options for us. One is video-assisted thoracoscopic surgery, which is less invasive, and the thoracotomy with decortication. This is preferably used in the second stage of empyema, whereas mini thoracotomy and decortication is used in the third stage. VETS has a potential to interrupt the progression of empyema. It decreases the pain, discomfort associated with prolonged ICT. It reduces the total duration of hospital stay and also duration of antibiotics. Now useful in patients with loculation within pleural cavity. There is one case report from India, which is youngest child of 20 days at Nanavati Hospital in Mumbai by Dr. Sanghvi et al. Limitation is availability of resources, but nowadays every pediatric surgeon is trained in minimal invasive surgery. The younger generations are definitely better than the previous generation in endoscopic surgery. Cost is limitation, but I think in our country cost of surgery, particularly in government setup, I don't think it does matter at all. Mainly in the articles, they say cost is a prohibitive for using VATS. But these are research coming from US, UK, where the cost of surgery is exorbitant. VATS like fibrinolytics are useful only if they are done early. So that is very important. So you should catch them early and don't wait till it goes through this stage where you have to do surgery and remove the pill, fibrous pill, so as to relieve the lung. Now there are various studies I went through. So as I mentioned, some studies advocate fibrinolytic therapy, some studies are for surgery. And most of this, so there is a lot of confusion. If you read the studies who are promoting fibrinolytic are mainly by the pulmonologists, and the surgeons promote surgery. But then we have to find a middle path between the two. These are various studies. This is an important paper published in Journal of Pediatric Surgery, more than 3,000 cases. They say that the pendulum has swung more towards fibrinolytic therapy, but there are certain patients who definitely benefit from early thoracoscopic surgery. So they need to stratify cases who will benefit from surgery. So coming to the last slide. So the latest evidence shows that both are equally effective, fibrinolytic therapy as well as VATS. Center with minimal invasive surgical expertise, VATS is a better option. It has shorter post-operative stay, reduced need for thoracotomy. Centers which lack in surgical minimal invasive procedures, fibrinolytic may be used first, and then if it doesn't work, may be referred to surgery. Children who present late decortication. So the take-home message from here is that there is no controversy in management of stage 1 and 3. Stage 2 empyema treatment needs to be individualized. Primary VATS or fibrinolytic followed by VATS depends on the local factors, patient factors, and the cost. Pediatricians and pediatric surgeons need to collaborate, and both should be involved in decision making from the beginning in the best interest of the patient. Thank you.
Thank you, Dr. Vishal, for finishing in time. Now, just one thing I wanted to ask. Fibrinolysis has been recommended for a few years now. I have never used it. I don't think Dr. Kittur or anyone else in Kolhapur used it. You work in a corporate hospital in Goa. Have you ever used it, or would you recommend its use, practically speaking, including its cost and everything?
We have used streptomycin mainly because it is easily available. Whenever you have a cardiology department in your hospital, streptomycin is easily available, and it does work, but streptokinase. Urokinase is not that easily available. The cost is around 2,000 per vial. It is available in 15 lakh units, and the dose is about 10,000 units per kg. And it does work in some patients.
Anyway,
no, it can, in my 1 or 2 patients, I have seen hemorrhagic and pain. It does cause a lot of pain. Streptokinase cause a lot of pain.
Thank you, Vishal. I think the best message you have given is torsion test is acute scrotum, explore as early as possible,
yes,
within 6 hours. And for empyema, if there is not draining and your ultrasound shows flakes or pockets of pus inside the chest cavity, I think exploration is the best treatment at that time. So early referral for empyema is the most important. I think that's the best message that you have given. Thank you so much.
Thank you.
Well played.
Thank you, sir, for such a great talk. Now I request the chairperson and the speaker to please proceed to the felicitation area.
Yeah. Good afternoon, and this is a post-lunch session. So I requested them, lights should be on always. Okay. And we can interact with you also. And my panelists are Dr. Sarada Dhanode, Dr. Deepa Firke, Amol Pawar, and Dr. Suhas Kumbha. 3 HODs, and one of them is Dean, and one of them is Honorary Secretary. So I'm blessed with all these HODs and Honorary Secretary. And I am a general practitioner from Nipani.
We are here as students, sir.
Yeah. So my topic is emerging and re-emerging infections in children. So what is emerging and re-emerging? So these are the infection caused by new or previously controlled pathogens that has begun to spread again. Okay, either it has to be new or they were controlled in between and now there is a resurge. So I'm not going to discuss emerging, that is not new, but re-emerging only. So we'll go with the cases. We'll start with the case. This was a 4-year, 4-month boy from Chikkodi. It was the first issue of non-consanguineous marriage. And here is a story. Fever for 25 days, body aches during fever, left-sided neck swelling since 7 days, means last 7 days, and loss of appetite. If a parent complains of fever for 25 days, you can guess what he must be or what his profession must be. Okay, he was a teacher. That's why he said that 25 days of fever. Okay. And there was no history of rash, joint pain, swelling, vomiting, or he had an occasional viral infection, but there is no significant admission, no need of any admission till now. Family history is grandmother had a fever, cough, cold 2 months back. So we tried to elaborate what is the contact history is there or not, because he has a fever for 25 days. So thinking of a chief complaint, fever for 25 days or 3 to 4 weeks, we can say, and a supraclavicular mass on the left side. So can you elaborate this further? What comes to your mind? Anyone? Yeah.
So now this is almost a fever which is lasting for more than 3 weeks. So most of the acute infections that we think of are gone. So when it comes to infections, either there are some lingering type of infections. And being in India, I would think of first is COX.
Yeah, tuberculosis.
Tuberculosis. Secondly, the few other infections that may come up with a lymph node and a fever, I would think of as brucellosis.
Brucellosis, okay.
And as there is a history that this child does have viral infections, and the grandmother also had some type of viral infection. So some viruses that may linger, I would think of, though adenovirus may not be that common by these 3 weeks.
25 days
but then
work less
I would think
likely.
of an Epstein-Barr virus, which may
Epstein-Barr
have,
virus
which
will
have
cause
slightly
bilateral usually, but
Yes.
supraclavicular, madam, you want to add some?
Supraclavicular lymph node usually is associated with intra-abdominal infections or intra-abdominal malignancies.
Yeah, malignancy should come. Anything you want to add, madam? This match is not fixed. Means they don't know the diagnosis. Okay, we are discussing like that only.
I would agree with Deepa that because it's a fever for 25 days and something very important is a supraclavicular mass, which most likely to be lymph node maybe.
Yeah.
So supraclavicular left, supraclavicular
left.
node.
It is left.
Supraclavicular node. I would definitely like to rule out any sinister other disease in this. Like, chronic infection, of course, definitely
Chronic
tuberculosis
infection,
comes.
second is a malignancy.
Second would be malignancy is high on the card, especially the malignancies which present with any intra-abdominal mass or maybe some lung malignancy.
Amol?
Most likely COX because there is loss of appetite also and there is history of grandmother having similar type of complaints.
So that the way that only the mass is there in the left supraclavicular. If it is a lymph node, we expect if it is a chronic infection, there should be a generalized part or upper cervical, other side involvement, which is not there. So that is making little doubtful suspicion from infection point of view. Specifically going towards left supraclavicular, it indicates some hidden type of any lesion like malignancy.
Yeah. As there is a fever, it is an inflammatory disorder. And inflammatory, that to subacute to chronic now, and these major groups, infection, malignancy, or immune-mediated disorder, we have to think of, and as rightly said. Birth history, there is no specific, but he has lost weight, means there is something going on seriously, okay? Because he was 16 kg, now he's lost almost 1.5 kg. His height is okay, means it is acute onset for that age. His height is okay. So now on abdominal, he has a palpable mass at the right epigastric, right hypochondriac, and right lumbar region, just above the umbilicus, firm to hard and non-tender. What you are sticking with infection, malignancy, and immune disorder, which comes now first, or some alteration?
Now I think malignancy will be high on cards.
Yeah.
Because considering the mass and the supraclavicular lymph node, I think malignancy should be high, but still we need to keep chronic infection as a second priority.
Again, sir, still if we get any details of that mass, where it is in this exactly situated, whether it's predominantly in the epigastric, right apron, lumbar, margins and other things, that will tell. It doesn't appear to be any organ in like more appears to be some.
Yeah, it was not a
some mass
liver
which
or
is
spleen. It is a specific different mass, and margins are ill-defined. Means it was coming from below, and it is firm to hard.
I am little surprised, Mahesh, because even with that mass you have written, you can palpate the liver separate.
Yeah.
You have written that 2 centimeters.
Yeah, that was soft. That 1 minute. Yeah, liver was part aside. It was not involved. It was soft.
So definitely at this stage, we definitely would like to have a better imaging.
Yeah.
To know where the mass is arising from.
Yeah. Now, we have discussed this fever for 3 to 4 weeks, left supraclavicular lymphadenitis, and abdominal mass. Now, this is a CBC, not helpful, just ESR is raised here. Otherwise, okay, eosinophils are 3%. Anything added or we are ruled out something?
Monocytes are 7%. Sir,
yeah,
there's monocytosis.
Yeah. Okay, not much helpful.
Yeah.
Is a X-ray like this. But I will show you different X-ray, not from this child. This child has definitely, yeah.
Yeah, superior widening.
Yeah, this child has definite major. This is not our child. Huh? This is something different. I just have a comparison of this. This is a supraclavicular mass that was a superior mediastinal syndrome, but our child X-ray was looking normal for me. And this was his, ESR is raised, CRP is high, J for AB, as you have said that we are thinking of tuberculosis, we have tried to do microbiological tests, we are not, HIV, HBsAg, hepatitis C is negative, and almost creatinine is normal. So, and liver function tests are also normal. So, PO 3 to 4 weeks, abdominal mass, supraclavicular nodes, weight loss of 2 kg, anorexia. We are left with differential diagnosis, and this is a abdominal sonography. Large solid homogeneous mass around 4 by 5 by 4 by 4 by 4 almost. Okay. Size. Now, we have added something, we have deleted something, or we are the same. And what next best possible you can do to come to diagnosis? We are not at diagnosis.
Yeah.
Okay.
I don't think that has added much to our diagnosis.
Yeah. Yes. It has not given any much clue to us. So what we should go now for?
We need to go for a biopsy of this mass.
Yeah, absolutely right. We have to go for a tissue biopsy now, because left supraclavicular lymph node was there or mass was there. We have to take up that mass, and here is that. We have done a CT. CT showed same. We are left with all this, and this is a histopathological report. He has said that it is tuberculosis and cryptococcal lymphadenitis. Will you agree with this, or you want to further dissect this?
Sir, this is a lymph node biopsy result.
Yeah.
Supraclavicular.
Supraclavicular.
Whether any biopsy of the mass was taken.
If as a treating physician,
biopsy of the supraclavicular node was done, and this was a report.
See, if it is not clinically matching with the case.
Do you agree with tuberculosis? Can we treat like a tuberculosis? Should we treat with like a cryptococcal? Or we should go further invest?
I think we should further investigate.
What else you like to do?
It's not fitting in the clinical picture of either a tuberculosis or even a cryptococcal.
You can do a culture of the mass.
Culture of the mass,
because it is a
CB-net of the mass, yes, absolutely.
Culture.
So nowadays we do, if lymph node biopsy is done, we have to send it for CB-net and tuberculosis culture also. And it is done free of cost at a government setting. You have to remember that. This child has come to me with this report, so I could not send the, but what we have done, we have taken a tissue block from that pathologist, and we have have a second opinion on this. And he said that it is a cryptococcal because he doesn't have a AFB in that. So it was a cryptococcal neoformis in an immunocompetent child. It was surprising for me also and to you also, because we highly suspected malignancy because abdominal mass and supraocular lesion are most like lymphoma like. Okay, so it was a bit surprise. Initially we started with both, as AKT was started, and we hold on the antifungal because we started with AKT because that is most common.
But I want to know, is this a presentation of, it's not even like abdominal TB, it doesn't present like this kind of a mass.
Yeah.
So
that's why.
TB was not really fitting and left supraclavicular. Malignancy was the most common.
Yeah, malignancy was the most common.
In this child. So whether we would have, I don't know, AKT starting upfront without having a definite diagnosis?
No, with the HPR report only. Histopathological report only, we have started with AKT, but he did not tolerate that AKT. We had written a letter to Amdekar sir. He said that in between these two, more common is a tuberculosis. So treat tuberculosis and have a second opinion on a histopathology, block that. So we got a second opinion that it is not a tuberculosis, it is cryptococcal because they have done a special staining with JMS stains. And you can see here cryptococcus, budding yeasts are there.
No, this was from the lymph node or from the abdomen?
From the lymph node, not from the lymph node. From the lymph node only. That same biopsy we have sent to Dr. Ajit Kulkarni. And he has given that we are dealing with a cryptococcal disease. A bit surprise for us. Okay. But he beautifully responded to antifungal. We have given only antifungal, amphotericin B and fluocytosine. I had a discussion with Dr. Tanu Singhal, who is an infectious disease specialist, and the mass was very troubling. He was not able to eat because that was pressing on an epigastrium, stomach itself. And he was not tolerating that, anything. So we at one stage thought that we should remove that cryptococoma and get rid of that. But after 10-15 days, that mass started resolving and he's completely all right with this antifungal line of treatment.
So that mass was arising from where? Cryptococoma of what? It's not of the liver, no?
Not of the liver, not of the spleen. It was a lymph node involvement and enlargement of the lymph node at that site.
Around the lymph node.
Yeah.
Very, very unusual.
Yeah, unusual. That's why we are presenting.
So what is the source in this child, sir? Like, how did this child get a cryptococcus?
Sir, you want to ask something? Yeah, absolutely right, sir. Yeah. Why? HIV was negative. So next comes the how immunocompetent he is. So we have done a PID workup in this child and that come negative. Yeah, DHR and NBT is normal. Yeah, we thought of that, PID workup. Yeah. Anything else you want to rule out?
My thoughts in this child was like whether it was an EB virus infection lingering and then going for a non-Hodgkin's lymphoma or something.
Hodgkin's lymphoma can present like this. EB virus will have bilateral and it is not that hard mass. Hard mass we are deviating from the EB. EB will cause bilateral. Am I right, sir?
Yes.
Bilateral lymph nodes more common and hepatosplenomegaly with ABV.
Correct. Virchow's node and
Yeah. That's why. Tissue diagnosis is more. So for us, tissue diagnosis is more important. And when you are doing lymph node biopsy, please see that it is sent to CBNAT and ask them to have a culture also on that same sample. Okay. And that has to be taken in normal saline, not formalin. Formalin will go to the pathologist. Normal saline will go to the government. Okay.
So the bottom line is that we always need to have a biopsy. Virchow's nodes means rightly, as you said, we would have thought of abdominal mass, either a neuroblastoma or NHL.
Yeah.
Most probably in pediatric, this will come as the first two diagnoses.
Anything you want? Sarcoidosis was not, it was a histopathological diagnosis. That's why sarcoidosis was thought. And sarcoidosis will not present like this. It has a skin sago-like rash, hepatitis, and uveitis, conjunctivitis, or uveitis. That is a triad, arthritis.
Sir,
Okay.
Why this cryptococcus neoform should present in a immunocompetent child? Because he didn't have any signs of immunodeficiency weight loss.
He asked something.
Whether it's a normal in a natural course or it is a atypical.
We tried to find out what is the cause of that, and the father was a teacher, and he was religious about the evening walk, and he used to go to the garden which is full of eucalyptus trees, and pigeons were there. Both pigeons dropping, and eucalyptus bark is full of cryptococcus. So that was the source. And they stopped going there. Okay. He was immunocompetent, and now he is healthy and hearty. Go to second case. 8 years Amit, fever for 6 weeks, intermittent, abdominal pain on and off for 2 weeks, right shoulder pain, reduced appetite and weight loss, had a splenomegaly, 2 centimeter form, liver just palpable, history of raw milk ingestion, father is a farmer, ultrasonography of the abdomen revealed multiple 2 to 4 millimeter ecopore focal splenic inflict. Amol, you want to?
As there is history of raw milk ingestion, and along with that fever, and also USG was suggestive of some splenic infiltrates. So splenic abscesses were
microabscesses, yes, so absolutely right.
Brucellosis
is high on card, yes. And what, you want to add something?
Yeah. So now this is a case where there is a fever, it's almost like a pyrexia of unknown origin with hepatosplenomegaly with multiple hypoechoic lesions at the splenic level. Along with abdominal pain. Abdominal pain is there. So most probably it is some chronic infection which is progressive with developing some complication. When you say spleen with multiple abscesses, it can be brucellosis, it can be typhoid also, or immunocompromised state.
Absolutely. Anything?
Yeah, when splenic infiltrates like that, one more thing you need to keep in mind is infective endocarditis.
Infective endocarditis, absolutely.
IE can have splenic infiltrates, even tuberculosis sometimes
tuberculosis can have
splenic we say appear like. In TB, I'm sorry, in typhoid you generally get big abscess.
Big abscesses,
splenic abscesses,
microabscesses are seen in
microabscess you get classically in brucella, infective endocarditis, tuberculosis, and plague in olden days we used to get in plague also.
And
so even IE should be thought of when patient comes with. That's the importance of getting an echocardiography done to rule out, because he's got a splenomegaly, he's got a prolonged this thing. Unless we screen him, we may miss vegetation.
Right shoulder pain. Anything you want to add, Deepa? We'll go ahead. This was a picture of microabscesses. They are very small, tiny, 2 to 4 millimeter only. So this is typical of brucella. Sometimes it can be infective endocarditis and plague in a good olden days. So now we are not seeing plague, so we are left with only brucella. Heart was absolutely normal in this child. Okay, and same thinking, infection, malignancy, rheumatological condition or immune disorder, anything. Once it crosses the 2 weeks of fever, you can thinking level should be same, like infection, malignancy, rheumatological or immune disorder. Splenic abscesses, we have already talked this, but his brucella test was negative, madam.
Sir, the gold standard for brucella is basically a culture which needs to be
absolutely.
4 weeks. And brucella test, the antigen that we test, there's something called as a prozone effect.
Absolutely.
Especially in the endemic areas when the antibody titer is very high. In such case, it usually antagonizes the combination of antigen and antibody, and because of which, even though there is a brucellosis, the test may turn out to be negative. So still, considering the clinical picture, we feel that it's still a high suspicion of brucellosis. So we should go ahead for a blood culture, and also if there's an abscess there, we can just drain it and also send it for culture.
Amol, you want to add something? Same. Okay, we'll go ahead. So she's absolutely right. We have done, because brucella was high on card, because raw milk ingestion, microabscesses typically, and we were suspecting this is brucella. Now the test has come negative. We have sent this test to Dr. Mantur. And Mantur is a person who has done thousands of brucella test. He's a microbiologist and his thesis was brucella. He continued his thesis up to retirement. And he used to collect all the blood samples that are sent to him to the pathology lab in a plain bulb, and he used to do brucella test on that. A screening test was Rose Bengal test, and then he used to confirm with standard agglutination test. So he has done that both the test, and he said that it is pakka brucella because it is positive in dilution. So Deepa has absolutely said that this is a Poisson effect. When the antibody titers are very high, you can get false negative test. Okay, like false positive, we have a false negative. So your clinical diagnosis has to be a strong one. Then only you can go ahead with this test. And in this child, what we have done, we have sent the blood culture to him, and we have sent the splenic aspirate also. And see here, Bacilla militansis on 11th day on a blood culture and 7th day from the splenic aspirate. So it was proved bacteriologically that it is Brucella militansis, and he responded very well to our 6 weeks therapy of rifampicin and cotrimazole. Okay? Yes. And we have more than 200 cases now of brucella. When you have to think of brucella, typhoid not responding, typhoid-like but not that sick, typhoid-like but in between well, and typhoid-like 2 weeks of fever, arthritis and splenomegaly. These three combination, a fever, arthralgia or arthritis, and splenomegaly, splenohepatomegaly sometimes. Lung involvement is very, very rare. I have not seen in 200 cases. Arthritis in a Shepherd family with 7 days also now. We have a child with 7 days of fever, and she has a right synovial fluid there, a pain there in a right hip, and brucella test positive. Nowadays, you can do PCR. 16-hour PCR is recommended to prove that. Now, going beyond this SAT test. Okay, but blood culture is a gold standard.
Just 1 minute, Mahesh. About the blood culture, all of us must remember that with Bactec now, it is easy to grow.
Yeah.
Previously, we had to wait for weeks and weeks for the brucella to grow. Now, with the Bactec culture, almost by end of first week,
yeah, that's a 7 day.
You can get. So it's not very difficult, not a very too long
and
time.
Easy to grow bacteria, like Salmonella typhi.
Yeah.
Brucella is easy to grow, not like H. influenza.
I would say the next is you can even go for a bone marrow culture.
Bone marrow culture,
If
yes.
the blood is not there, take a bone marrow culture, send it for Bactec. Definitely by 1 weekend, you may be able to get an organism.
And why you have to diagnose brucella? Because it is a treatable cause. And, yeah. Yeah, you have to keep that Bactec bottle for at least 2 weeks.
At least 2.
At least 2 weeks. Anything you want to add? Yeah. Hey, आवाज कहाँ है रे? Diagnosis is easy. Yeah, what's your diagnosis?
Sir, usually we don't get a cough as a presentation in infants, especially in this age group.
Yeah.
And this child does have a cough. So my diagnosis may probably we are dealing with a pertussis.
Yeah. Anything else? Because we do not do culture and all these things. It is a clinical diagnosis actually. Yeah. Anything else you want to see on CBC or something like this?
Still, at a 3-month baby having a dry cough, it's more of a spasmodic cough, the way he was coughing with hoarseness into that. First DD will be pertussis, what we could even in this year because of this re-emerging of the old infections. Second, whether it can be a chlamydia or adenoviral. Third is adenoviral, which can present like pertussis like cough presentation.
Yeah.
Possibilities.
Yeah. Anything you want to add? A chlamydia, yes, a febrile pneumonia syndrome it carries, but doesn't have that much cough, and the clue will be he will have a conjunctivitis by that way in a neonatal period. after 1 week or 2 weeks, he had a conjunctivitis-like presentation with this milder cough. This will not be that much cough. Chlamydia, one of the treatable causes. Okay, that should be thing. Adenovirus is a full red eye and there is no perilimbal sparing. Okay, conjunctivitis. That is the difference between Kawasaki and adenovirus. There is no perilimbal sparing of that.
Older children, you will think of mycoplasma. That
Mycoplasma.
is the typical paroxysmal.
Yeah, paroxysmal. Pertussis cough. We can call it as a pertussis cough. In older children, chlamydia, mycoplasma, same group, no cell wall.
I want to tell Mahesh, we had recently a case on Saina that's done the bronchoscopy. 2 months baby, continuous cough and with sputum production. First time I'm seeing that. Turned out to be bacterial tracheobronchitis. Staphylococcus aureus has grown from everywhere. Secretion, blood culture, everything. That baby used to continuously cough like this.
Yeah.
Cough like this with productive sputum. And when the scopy was done, we were shocked to see pus coming from trachea, bronchus, everywhere. And everything has grown Staph aureus. So I've seen a newborn coughing, which was not, this was a dry cough.
This was a dry cough,
which is productive with sputum.
And what was the ultimate diagnosis of that purulent broncho?
Bacterial tracheobronchitis.
Tracheobronchitis. But does he have cystic fibrosis?
No, we have sent it for now for underlying things. We are just working up for
because Ball has gone Staph aureus? Yeah. And Pseudomonas? No, no Pseudomonas. Okay. If there was a... Okay. Okay, but our child of cystic fibrosis had Staph aureus and Pseudomonas both. Yeah. But that is there, but our child was only 6 months old. Our Nipani child. Okay. We had a case of cystic fibrosis and that was a persistent pneumonia on a right upper lobe and failure to thrive and metabolic alkalosis. So you don't have any other diagnosis. Metabolic alkalosis, persistent pneumonia and failure to thrive is equivalent to cystic fibrosis and that was proved by whole exome sequencing. Yeah. And we have sent that child to the cystic fibrosis clinic in Bangalore, but child expired, but they were ready to help with that Cliron something, exocrine pancreas enzyme. And that is costlier. So we added this is a new case. So 4-year child had a strawberry tongue, okay, and rash like this. We have already, Tushar sir has already discussed this, and there is a rash over this. Yeah.
Scarlet fever?
Yeah, absolutely, bang on it. And what is the difference between this and other rashes? They are there, and there is some eosinophilia here. Is there any relation of scarlet fever and eosinophilia?
Allergy component?
Yeah, it is a toxin-mediated disorder and it is only bacterial infection which has got eosinophilia in the 2nd week actually, but sometimes we have seen as early as 2 or 3 days also. If there is 5% eosinophilia now, it will go to 10, 15 or 20% by the end of 1 week. And that is a clue sometimes. If you do CBC at the end of 1 week and eosinophilia or toxic granules with eosinophilia in the first few days and sandpaper like rash is scarlet fever. And diagnostic test nowadays, you do rapid antigen test, a throat swab. Okay. And this was, eosinophilia was described right in 1935. Yeah. And we had all epidemic of that. Now it is coming down. Okay. And there are scores, Centaur or McClax, all these scores can for that Streptococcus pharyngitis. And rapid antigen test or throat swab culture is a gold standard, but now it was difficult to get rapid antigen test in between. And we have procured that 50 strips and now scarlet fever has gone. Okay. What to do with that 50 strips? That is my question. Okay. This is examples of freaky disquamation in a scarlet fever and peri-ungual as described in Kawasaki. This is a BCG reactivation in Kawasaki, and that is a Kahn-Kappa disease of rickettsia. Okay. Last case, we have got 15 minutes, so we'll go slow, no problem. We'll discuss. A 5 years girl, a fever on and off since 6 months now. 15 days, 4 weeks, now it is up to 6 months. Cough on and off 6 months, weakness since 5 months, breathlessness since last 4 to 5 months. She was from Shepherd family, and there is a history of raw milk consumption, but it was not fitting into brucella. Okay, because 6 months of fever, ill-looking child, distress, hypoxia, requires 5 to 6 liters when she came to me, clubbing present, pallor, GVP raised, no edema, cyanosis present. Weight was 15 kg only, pulse was tachycardic, tachypneic, BP was maintained though, bilateral co-scriptation, suprasternal indrawing, intercostal indrawing, CVS has a gallop rhythm, hepatomegaly 2 cm but soft, and spleen was 2 cm firm. So we'll go back to 6 months of fever and cough. What's your thought process?
It's a very prolonged history, and coming to the last part of it, she has definitely gone into chronic respiratory insufficiency.
Yeah.
Requiring oxygen, and she has also developed clubbing. So there's signs of chronic hypoxia.
Chronic hypoxia is there.
So it's some kind of
means what we have ruled out and what we are in by these 6 months of fever. So all pyogenic infections ruled out. Tuberculosis also almost ruled out because 6 months. Either she has to recover on treatment or she has to die.
So it can be one of the things we need to rule out whether she has any underlying immunodeficiency.
Yeah.
Because the way she has progressed. Any other chronic infections like HIV status I would like to know in this patient.
Absolutely, madam.
Because we want to know whether she's having any kind of interstitial lung disease.
Yeah.
Which is causing this kind
of
hypoxia.
On detailed inquiry, madam, actually, the child has fever, milder fever since 1 year. And first complaint was she's weak. She has stopped going outside. So where is your thought process is absolutely right. Interstitial lung disease will present like this. Anything else you want to, Amol, add?
Pneumonia means interstitial lung disease only.
Okay, absolutely. Not a pneumonia or pyogenic almost gone, tuberculosis gone, atypical infections also less likely now. We are dealing with some other disorder.
Sir, the way the case what has been said, it's a 5-year girl, fever on and off with cough. So it is not a continuous progressive illness.
Yeah.
It's a repeated infection the child is getting in where there is maybe some systemic immunocompromised state that is causing infection. The breathlessness component is for 4 to 5 months. That appears to be a continuous. So there is a progressive breathlessness that indicates that there is some progressive either lung or cardiorespiratory pathology that is getting going into more severe situation with JVP raised suggestive of core pulmonar or right-sided heart failure.
Yeah.
With chronic suppurative airways may be the possibility or pulmonary disease, chronic pulmonary.
Yeah. I'll just show the videos of this child. We have already talked this fever since 1 year, milder fever, but weakness was more. She stopped going outside, gradually now bedridden only, does not move at all now at this point of time. So, she doesn't appear to be tachypneic, means a distress, but she's hypoxic. Okay, she required 4 to 5 liters to maintain 94 only. Okay, and she tachypnea was there.
So
and
considering this long duration course, and there's a history of weight loss, and probably there is an interstitial involvement. I'm not sure yet whether she's immunocompromised or not, but we need to think of PCP, which will have interstitial
pneumocystic, and you want to say PCP. Okay.
Yes.
Anything else?
I don't know.
On card we have anatomy is interstitial lung disease, most likely, and that has caused something like this. And your immunocompromised status you have to look for. She was HIV negative. Anything else you want? Now this is a picture. Both the lens fields are inhomogeneously filled. Reticuloendothelial markings are prominent, and this was the latest one.
Yeah, that's progressive worsening of the X-ray.
Progressive worsening of the disease, which is uncontrolled with multiple antibiotics. She received a tubercular treatment also, which was not needed, I think. But she had this polymorphonucleoleucocytosis.
There's one more thing, Mahesh, I just want to ask, will you consider any inflammatory causes like, causing lung disease? Vasculitis.
Vasculitis, yes. But her age and typical presentation, it was only 1 year or 6 months. Okay, and she doesn't have any rash.
Was there any hemoptysis?
Hemoptysis, you should ask about hemoptysis. No. In this case, it was not there, absolutely, madam. Small vessel vasculitis can present like this. Vaginous granulomatous structure is not there in children, but small vessel vasculitis will present, or pulmonary and kidney syndrome. That.
So multi-system?
Yeah, yes sir, absolutely right sir. No infective endocarditis in this child. We have done echo, but galloprhythm was there, she was in failure, but that was because of right-sided failure, cor pulmonale.
Can you,
there's a multi-system involvement in this child,
you said
sir.
There is a history of contact with the, Shepherd community.
So
and all
we are
that.
not able to get that.
Do you think of Mycobacterium bovis?
Mycobacterium bovis, but we have not done that.
Presentation will be like TB, but I'm just asking whether will you consider that?
Yeah.
Because that's also something which is coming up now. We are seeing more of Mycobacterium bovis.
Truly speaking, madam, I have not considered that as a possibility in this case. Yeah.
I'm not sure, but if it would have been a short duration with this multi-system involvement, hepatosplenomegaly, interstitial involvement, mycoplasma is if in case like in the short duration, but this long duration,
1 year almost.
It won't.
Clubbing, chronic progressive disease. So on CT or on X-ray, she had bilateral pneumothorax.
Oh.
Bilateral pneumothorax, and Raja Ramikant from KIAM used to say that if you say bilateral spontaneous pneumothorax, first 10 diagnosis will be LCH. I was there in Aurangabad, then he said that histiocytosis X at that time, but now we have abandoned that histiocytosis X, let us say, or Hanschler. We are now confined to that LCH. Okay, there were lung cysts in between. It was not clear, but CT has showed, and bilateral pneumothorax with this chronic progressive, but there was no seborrhea in this case. There was no ear discharge. We have had a nail dystrophy, 20 nail dystrophy, also one case with Narendra that turned out to be a LCH. And he had one more case after that, which was a huge splenomegaly with LCH. And this was
skeletal lesion she had?
Huh?
Bone lesion?
Like bone lesions were not there. Not there. It was very atypical. Pulmonary involvement in LCH in a children is very, very rare. They involve usually skin, bone, and spleen. Major organs are liver and spleen, bone, and skin. But it was thought only. It was not proved by biopsy. We thought of only LCS because there was bilateral pneumothorax. It is open for discussion that what else it can be. Okay. Yeah. Adults, yeah, that's why. That's why I said that on query LCS. It is not a definitive diagnosis because we have to have a tissue diagnosis for that. Yeah, hepatosplenomegaly. This child didn't have that also. Huh? Seborrhea, ear discharge will put this. We are clinically sure that we are dealing with LCH, but she has only, because I have shown the video also, there was not, she doesn't have any seborrhea, she doesn't have any nail dystrophy, clubbing was there, but. So, one of the did, yes. only lung presentation in glycogen storage is very, very rare. Yeah. But only as a presentation, as she presented as a fever and weakness. So weakness will, Amdekar will say that, no, it is weakness means either it has to be hypoxia or prolonged hypoxia, that's why weak. So she presented with sign of hypoxia, means interstitial disorder without any cramps, without any wheeze, without any distress, started 1 year back. And gradually progressive disease.
Her echo was okay? There was no pulmonary hypertension? Echocardiography?
Echocardiography only, we have not done that also because she left against medical advice within 2 days from us. But she was treated as a LCS in my colleague's center, but she partially improved, and once she started improving, they again left there also. So what happened to this child, I don't know really. But it was an interesting case, that's why I said that we'll present, though non-infective.
Clinical presentation, we wouldn't have thought of LCH first. Just the clinical,
absolutely,
because she's not having skin, there's no markers to suggest.
CBC? Yeah. LED, like. Yeah. Yeah, height was normal, means it has started within this 1 year only. Multiple episodes, leukogen identification will start presenting from the infancy onward. Yeah, they will not. Yeah. But, yeah. PID high on card, okay. CVID high on card. So this was an interesting case. Not diagnosed yet, and probably she has expired. I got a news that she has no more. So that's why I said that I will present this case. She was treated with AKT, like this. Macox Z is at that time, in 2015. Visolon was also given. But it was not a case of tuberculosis, definitely. Thank you very much.
Thank you, ma'am and sir, for such an enriching learning session for all of us. I request all the dignitaries to proceed to the felicitation area.
Benign epilepsy with centrotemporal spikes or childhood epilepsy with centrotemporal spikes. Now the new term is the self-limited epilepsy with centrotemporal spikes, and the treatment is oxcarbazepine or carbamazepine. So few things about the self-limited epilepsy with centrotemporal spikes. It has mandatory features, that is focal seizures with dysarthria, drooling of saliva, dysphagia, and unilateral clonic seizures. And seizures occur during sleep, and they occur within 1 hour of falling asleep or 1 to 2 hours prior to awakening. And EEG shows high amplitude spike wave discharges. And important thing is the remission occurs by mid to late adolescence and around puberty, and there will be no developmental regression. However, an MRI is not required for diagnosis, but should be strongly considered in cases with alerts. So what are the alerts? If the seizures last more than 30 minutes, if seizure frequency more than daily or only daytime seizures, or EEG shows sustained focal slowing or persistently unilateral centrotemporal abnormalities on serial EEGs, or lack of sleep activation of centrotemporal abnormalities on EEG, or age more than 12 years, or intellectual disability, or any neurodeficit. In all these cases, we should do MRI brain. And there are few exclusionary criteria also. Next case is the 3-year-old male child. He has severe vomiting with sweating and deviation of eyes and head to one side, lasting for 10 to 15 minutes with impaired awareness. So there is focal seizure, deviation of eyes to one side, then severe vomiting and sweating, so autonomic features. And the seizures were slightly prolonged. And he has 2 episodes in last 3 months. And his EEG is suggestive of bilateral occipital spikes. So here you can appreciate he has bilateral occipital spikes. So this is previously known as Panaytopoulos syndrome or early onset occipital epilepsy. And a new term is the self-limited epilepsy with autonomic seizures, SELES. So new term is the SELES. And in this case, there is focal autonomic seizures that are often prolonged. EEG shows high amplitude spikes in occipital region. Seizures were infrequent in these conditions, and remission typically within a few years from onset, and it responds to carbamazepine. So this is the new group of the epilepsies. So I will discuss 3 groups of the epilepsies. So I have discussed about the self-limited focal epilepsies. So it contains SILIs, just I have discussed, selects. Then there are other 2 groups also, childhood occipital visual epilepsy, that previously known as Gestalt syndrome or late onset occipital epilepsy, and also photosensitive occipital lobe epilepsy. So it has typical features, that is age-dependent occurrence, antecedent history is normal, cognition, neurological examination normal, remission usually occurs by puberty, and it has classical seizure physiology, semiology, just we have discussed, and specific EEG features. So this is SELPs, self-limited focal epilepsies. Now the term benign, they now no longer recommended because it fails to acknowledge comorbidities. So what are the comorbidities? Some select patients may have learning disabilities or behavioral issues. So benign is no longer recommended. The word is the self-limited. And the term idiopathic epilepsy is now restricted only for 4 syndromes like childhood absence, juvenile myoclonic, juvenile absence, and epilepsy with myoclonic, epilepsy with generalized tonic-clonic seizures. Next case is 7 years old male child. He has focal impaired awareness clonic seizures, all have focal seizures in sleep since last 3 months, and he has cognitive impairment since then. He has last 3 months he has multiple episodes and cognitive impairment. He has scholastic regression and also speech regression. So this is his video. He has focal clonic seizures in sleep. Here also. So his EEG suggestive of bilateral continuous spike wave discharges involving left side frontocentral and right side temporal region. So this is CSWS, that is continuous spike wave discharges in sleep, is the previous name. His MRI was normal. So now new name is the DE-SHOS, that is developmental epileptic encephalopathy with spike and wave activation in sleep. So this is new group of the epilepsy, DEs, that is developmental epileptic encephalopathy. So first we have seen SELPs, now DEs. So DEs contains, previously Douce syndrome is replaced by epilepsy with myoclonic atonic seizure. Then epileptic encephalopathy with CSWS is replaced by DE-SHOS, that is developmental epileptic encephalopathy with spike wave activation in sleep. Then acute encephalitis with refractory repetitive partial seizure or devastating epileptic encephalopathy in school-going children is replaced by FIRES. So our case is the DE-SHOS. So started oral steroids and valproate, his seizures decreased, but they were persistent after adding clobazam, seizure stop, and he has also scholastic and cognitive improvement also. Next case is it is an interesting case. So 10 years child, he has febrile seizure at 3 years of age and he has sudden brief movements of upper eyelids, brief, lasting for 3 to 4 seconds, with brief loss of awareness, sometimes with uprolling of eyeballs since last 1 year. So just observe his eyes. Just these moments. Sudden myoclonic jerks of upper eyelids with slight uprolling of eyeballs. In this video, just lasting for 3 to 4 seconds. Sudden uprolling of eyeballs with a few myoclonic jerks of upper eyelids. So his EEG, when EEG has been done, it suggests of generalized spike wave discharges, and it lasts for 3 to 4 seconds. So in between these 2 thick lines, there is 1 second. So 3 to 4 seconds, he has generalized spike wave discharges with these movements. So this is epilepsy with eyelid myoclonia. So started tablet valproate and his seizure stopped within 1 week. So now the third group, that is genetic generalized epilepsy. So we have seen SELPs, DEs, and genetic generalized epilepsies. In genetic generalized epilepsy, new names are previously this syndrome is called as Jivan syndrome, and it is replaced with epilepsy with eyelid myoclonia. And there are other conditions, that is Bureau and Tachinari syndrome, name has been changed to epilepsy with myoclonic absence. Next is common one, 8 years old girl. She has repeated episodes of suddenly stop talking and stare blankly in the space, and she doesn't respond to surrounding people, and each episode lasts about 10 to 30 seconds. Similar episode 10 to 15 times per day since last 2 months. So just observe after 30 seconds of hyperventilation, during hyperventilation, she stopped, staring look, and there is also imbalance without fall. There are also mouth automatisms, then after that right hand automatisms. And the entire process lasted around 30 seconds. She will become normal after 30 seconds. Now she became normal. So this is typical absence seizure. And EEG showed classical 3 Hz spike wave discharges. 3 Hz means in 1 second, just I have described, in between these two thick lines, there is 1 second, so we are getting 1, 2, 3 spike wave discharges. So this is childhood absence epilepsy, and it responds to valproate or ethosuximide. Next case is now few pediatric neurology cases. 5-year-old male child, he has sudden onset choreoarticular movements since morning. In the morning, 8 o'clock, his movement started, and he came around 12 o'clock to my OPD. There is no history of URTI in previous 2 months or no other significant history. So his video, just observe his left upper limb. There are continuous movements of left upper limb, and after raising the hand, there is downward and outward movement of the left upper limb. So it is pronator sign. So this is chorea, unilateral chorea. Here also, in this video also, just observe his left upper limb. There are movements, and also at shoulder joint also. So this is unilateral chorea since morning. So MRI has been done, which suggests there is hyperintensities over the caudate nucleus, right caudate nucleus. So he has left hemichorea and right caudate nucleus, we are getting hyperintensities. So MR angiography done, which was normal. So other investigations of chorea we have done. Antisyptolysine O titer, CRP, ESR negative, echo was normal, antinuclear antibodies negative, CSF normal, serum MOG negative, thyroid function tests were normal, CSF IgG negative. So all the investigations were normal. So what are the causes of acute chorea? It can occur with autoimmune conditions like rheumatic chorea, SLE, autoimmune encephalitis, hyperthyroidism, vasculitis, or toxic causes. And in pseudonym chorea, 20% present with hemichorea, and at the time of chorea, sometimes we don't get all the inflammatory markers and other Jones criteria. So acute chorea, and 96% of cases we get pseudonym chorea, and 20% patient present with hemichorea. So we ruled out other secondary causes, and diagnosis of exclusion is the pseudonym chorea. So he responded to oral steroids. One RCT showed that rheumatic chorea responds beautifully to oral steroids, and after that we started injection Penidura. So how to explain MRI pictures? So there is one study which shows that non-specific signal hyperintensities also seen in white matter, brainstem, and caudate nucleus in 47% of patients. So it can match. So this is pseudonym chorea. Next case is the 10.5 years male child. He has focal aware. This is aware. Focal aware clonic seizures lasting about 30 seconds since last 1 year. So just observe his video. So there is focal aware clonic seizures. He was aware that time with drooling of saliva and lasting for 30 seconds. And he has multiple episodes in last 1 year. And his MRI suggests you of lesion in the right medial temporal region with cystic changes with few hypo and hyperintense lesions. In T2 weighted images, there is hyperintensity, and T1, it is hypointense. So it is heterogeneous mixed hyperintense and hypointense signals and few cystic areas. So this is the diagnosis of DNET. So dysembryoplastic neuroectodermal tumor. So started oxcarbazepine, and if drug resistant, neurosurgeon will say that they will intervene. Next, 12 years female child. She has 3 episodes of focal impaired awareness clonic seizure in sleep in last 2 months, but her seizures were prolonged, and she has impaired awareness with impaired awareness. So this is her video. There is, to start with, there is deviation of eyes to right side, deviation of eyes to right side, and then clonic movements of the mouth, and it lasts around 10 to 15 minutes. She has now left dinette. So on the left medial temporal region, we are getting hypointense and hyperintense on T2 and hypointense on player on T1. So this is also dinette. So neurosurgeon opinion taken. He also advised if drug resistant, we will do neurosurgery, and started tablet oxcarbazepine. She also required add-on tablet clobazam, and she has no seizures since last 3 months. So dinettes are WHO grade 1 glioneural tumors. They are slow growing supratentorial masses, and they have minimal or no neurological signs other than seizures. And they are just described T1 hypointense and T2 hyperintense, and surgery indicated for refractory seizures. And recurrent seizures, risk factors for recurrent seizures were age more than 10 years and longer duration of epilepsy prior to surgery. Next case is the 11.5 years old male child. He has 2 episodes of unprovoked generalized seizure. Unprovoked generalized seizure. So, and 1 episode of febrile seizure at 1 year of age, and no history of headache. But his EEG showed focal discharges over the right frontal region here. So his MRI is suggestive of big mass over the right frontal region with some cystic changes, with hyperintensities, with perilegional edema and midline shift. So excision of tumor has been done, and it is oligodendroglioma, WHO grade 2, and it is diffuse low-grade glioma, and he did not require chemotherapy or radiotherapy up till now. Next interesting case, this is an 8 months old male child of 3rd degree consanguinity. It is a normal birth history, no perinatal events, and global developmental delay with microcephaly. So consanguinity, global developmental delay with microcephaly, and he has epileptic spasm since last 2 months. His EEG was suggestive of West syndrome, and he has blonde hairs. So just observe his video. He has blonde hairs, and at the last part of the video, there is epileptic spasm. This is flexor epileptic spasm. So, and his EEG suggestive of multifocal high amplitude spike wave discharges over both hemispheres, suggestive of modified hypsarrhythmia with disrupted background. So this is West syndrome. So we investigated, MRI is done, which showed mild cerebral atrophy. Other investigation, thyroid, serum ammonia lactate were normal, so started steroids and valproate. But in view of blonde hairs, consanguinity, microcephaly, and developmental delay, just I have written, this is phenylalanine levels were done, and it was significantly raised. So it was 1183 micromole per liter. So genetic study has been done, and it is phenylalanine hydroxylase gene defect on exon 7, and it is homozygous, and diagnosis is the phenylketonuria. Genetic counseling by Dr. Datta sir from Pune has been done, and then phenylalanine restricted diet started, and he has no epileptic spasms after starting phenylalanine restricted diet, and there is a developmental improvement, and his hair color also changed. So he is better, no epileptic spasm, hair color also now black. So, but the problem with phenylketonuria is dietary treatment appears to reverse all signs of PQ except cognitive impairment that has already occurred. So, few things about the phenylketonuria. Phenylalanine hydroxylase catalyzes the conversion of phenylalanine to tyrosine. It is an autosomal recessive disorder, and most cases are caused by phenylalanine hydroxylase deficiency, and 2% patients with hyperphenylalemia have defects in tetrahydrobiopterin mutations, and tetrahydrobiopterin is a cofactor required for phenylalanine hydroxylase activity. And the hallmark of the disease just described: irreversible intellectual disability, seizures, microcephaly, behavioral abnormalities, and eczematous rash, and light pigmentation. And the body and urine may have mousy odor due to the increased concentration of phenylacetic acid. So diagnosis just described elevated serum concentration of phenylalanine, and molecular analysis used to confirm PQ through identification of phenylalanine hydroxylase mutations. And dietary therapy requires the use of medical foods including phenylalanine-free protein substitutes. Next case is 9 years old male child has abnormal movements of upper and lower limbs with rapid breathing with vivid recollection of events lasting for 10 to 15 minutes in latter part of sleep. And he had multiple episodes in last 1 year. So just observe his video. He has violent movements of the lower limbs and also upper limbs, and he continuously does these things for 15 to 20 minutes. So upper limbs also abnormal movements. So his EEG was done, which was normal. So he has vivid recollection of movement, vivid recollection of events, and also these violent movements. So diagnosis is the REM sleep behavioral disorder. It is rare in children. So it is characterized by the behavioral enactment of unpleasant and combative dreams with complex movements that can be vigorous and violent because of lack of atonia during REM sleep. It is uncommon in children, but may be seen in association with the use of some drugs like fluoxetine or accompanying narcolepsy or Tourette syndrome. And these episodes respond very well to small doses of clonazepam given at bedtime or melatonin. So he responded to melatonin. He has no episodes after starting melatonin. Next case is 6 months baby. He has tremulous movements of all the limbs after bathing and lasting for 10 seconds. Birth history and developmental history normal, no pallor, CNS no deficit. So you tell me what is the diagnosis? What is that? Infantile tremor. Child is developmentally normal. No pigmentation. Hemoglobin normal. His EEG normal, sugar normal, calcium normal, vitamin B12 normal, hemoglobin normal, everything normal, developmental normal, everything normal. It lasts after bathing 10 to 15 seconds. What? What water? Epilepsy. EEG is normal. So it is benign condition. So which benign condition? So I think it can be jitteriness. We can call jitteriness, but 6 months is slightly older age to call jitteriness, so I call it shuddering attacks. So shuddering episodes are characterized by periods of rapid tremor of the head, shoulders and arms that resemble shivering. So he has movements of upper head, then upper limbs, lower limbs, so everything. During a spell, there is no change in consciousness or color change, and the episodes last several seconds. And they are often triggered by excitement, frustration, embarrassment, or surprise. Sometimes after bathing, they got excited, so it can occur after bathing. So every time it occurs after bathing. Onset is in infancy or early childhood, and they typically abate as the child grows older. And the differential diagnosis includes benign neonatal sleep myoclonus, jitteriness, epilepsy, benign myoclonus of infancy, and tremor. So preservation of consciousness, predictable triggers, ability to abort an episode when distracted by a parent, and normal EEG distinguish this entity from seizures. Thank you.
Thank you, sir, for enlightening us with newer cases and names. I request all the respected faculty to proceed to the felicitation area.